my friend and colleague, Dr. Stephen Schutzer, kind of orthopedic surgeon extraordinaire. He created a real orthopedic center of excellence, has been leading the moving to value movement for many years. And kind of just an incredible person. Steve?
Well, thank you very much, Paul, and welcome everybody to this webinar. And we thought that since there are a number of folks that are new to the Alliance and new to the group here, that we would just share a little bit of interesting history, how we got here. Because, you know, there's always a backstory to these movements. And our story started with an event in April 2019 where my organization, CJRI, sponsored an annual lectureship at the Connecticut Health Council. This year we sponsored Dave Lansky, the president and CEO of PBGH. And the night before his presentation, we sponsored a dinner at the Marriott for 25 people. We intentionally had a few payers and brokers and providers and a swath of the whole ecosystem. And it struck us that there was some common theme in what we were hearing. So 5 of us, probably because we wanted to have another cocktail, but allegedly to talk about the dinner meeting, said, everybody is saying the same thing. Every stakeholder said we're investing capital and resources into this thing called value-based healthcare, but not seeing any ROI. So at the same time, my friend Jeff said, employers think providers are tone deaf. At which point I replied to Jeff, where are the employers and why don't they answer their darn phone calls or emails? Because we've been trying to bang on their doors for years. And it was a classic supply-demand side disconnect. But we saw there was an opportunity to focus specifically on the needs of the employer-provider relationships. And that was sort of the genesis of this. And this was in the spring, and we scrambled to put together our first symposium, which was held in early December at the Delamar Hotel. We got 130 people to come, and we had some national level speakers, got really inspired and excited about this. And we found our way with the Connecticut Health Council, became a separate working group looking at employers and providers. We put on our second forum a year later, December 2018. This time the focus of this meeting was on primary care modernization, centers of excellence, and why are we paying so much for pharmacy? As you know, we were planning on our third symposium in March of 2020. We had to unwind that like so many other events, but I just want to give you some numbers here. Since that time, March of 2020, we have produced 11 webinars and 105 presentations by local, regional, and national healthcare leaders. So the next landmark in our evolution was something that we all credit Paul Grady with. And he said, hey, you guys, you ever read this book, Finding Allies and Building Alliances? The answer was no, but we grabbed it. Great weekend read. If you haven't read it, I'd encourage you to do so, because Governor Levitt is a very, very compelling story about why do some initiatives work and some don't. And these are the 8 elements that bring people together, more importantly, keep them together. We decided at that point that we would then become a value alliance. So we morphed our mission from the mission of this alliance is to create a value-based healthcare ecosystem with the highest quality outcomes, reasonable costs to employers in our state and their healthcare consumers. So we became a value alliance. As you may know, that at the pinnacle of these 8 elements is somebody who the community would view as a convener of stature, somebody who kind of stands above the fray, mutually respected by all stakeholders. When we first launched the alliance, Karen Gee, who was a senior vice president of Pro Health, did a fantastic job getting us started. And for the first year or so, we focused on Connecticut Compact Committee, Centers of Excellence, primary care modernization, and our annual symposium. More recently, Karen has transitioned out. She's left town for a bit, and we were very, very fortunate to have Dr. John Rodis, who's one of my mentors, come on as our latest convener. And as you've heard, we were also very fortunate to partner with 365 Media, Don and RD and Karen, to help us really grow this community because everybody's voice needs to be heard. We're focusing on the Connecticut cost growth benchmark, growing every aspect of this community. We love the concept of advanced primary care, and we will be producing our annual forum. You'll hear about that in June. So this is the current executive board and executive structure. So what I'm going to do now is introduce our moderators. The first moderator probably needs no introduction, but I will anyway. This is my friend Jeff Hogan. Jeff is president of Upside Health Advisors, where he consults with payers and large provider groups on new product development and as a resource for employers on strategies to manage their healthcare spend. Jeff has numerous focuses, including payment reform, health policy, care transformation, value-based healthcare, and even precision medicine. He recently retired from Rodis Benefit Groups after an illustrative 30-year career where he was a Northeast regional manager. Jeff is a highly sought-after speaker and regularly appears on national forums, which are focused on all aspects of the healthcare value agenda. He serves as the Connecticut liaison for the National Alliance of Healthcare Purchasers Coalition and the regional leader for Leapfrog Group. Jeff is one of our founders of the MTVA and serves on our executive committee, and it's just great to have Jeff as a partner and a friend. Second is Dr. John Rodis. John is the founder and president of Arista Health, a healthcare consulting company whose mission is to drive quality, safety, and patient experience, and to reduce risk in hospital and health systems. John served as my president here at St. Francis from 2015 to 2020, and was the first physician to serve as St. Francis president. Under his leadership, St. Francis was awarded the distinction as one of America's 100 best hospitals for patient experience, one of the nation's top 1 hospitals by IBM Watson, and one of the world's best hospitals, top 1,000. And while John was president, this is like the Michael Jordan of awards. St. Francis attained 5 consecutive A ratings for patient safety from the Leapfrog Group. John currently serves on the Board of Trustees for the University of St. Joe's as a member of HealthGrade's Quality Advisory Board. Recently he's a lifelong learner, and John became certified by the American College of Lifestyle Medicine. John is our convener of stature for this great organization. So with that, Jeff, let me turn it over to you to introduce our speaker and take it from here. Thank you.
Very good. Thank you, Steve, and thank you, Paul, for that context and really excellent introduction. We're really excited about the prospects for our Moving to Value Alliance community, especially with this discussion today. We have a national audience now, and it's the reason we moved to this one o'clock location. So I'd like to welcome all of our existing Moving to Value Alliance members, and especially our newer members that have joined as well. We encourage you to join our online platform where we'll continue today's discussion with any of the questions that aren't answered during the discussion. We'll take it to there afterwards. And before I introduce our guests, I'll ask each of you to use the chat function. And Paul mentioned this earlier, to enter questions as we go that you'd like for us to ask at the end of this session. Those that aren't asked during the session, we're going to transfer over to our online platform to continue the discussion. And if you haven't already done so, I'll ask that you mute yourself as well. So it's really my pleasure. I'm so excited to have a conversation today with my friend John Rodis and Christin Deacon, who is a really good friend and colleague at this point, who has shown up on the national front as a thought leader. And first off, I'd like to welcome Christin Deacon and thank you for joining us. I'm going to give a quick bio because we have a whole ton of questions we want to get into with you, some pithy questions today. Real quick, at present, Christin is the Senior VP at 4C Health Solutions. She can talk about that some more in a few minutes. But previously, she served as the Health Benefits Director of the State Health Benefits and School Employee Health Benefits Plan for the state of New Jersey, which represents over 820,000 total lives and oversight over a $7.2 billion total spend, $7.2 billion. Prior to that, she served as the Deputy Attorney General for the New Jersey Attorney General's office as well. So I could go on and on with a resume, but we just wouldn't get through our questions, and we want to get to them fairly quickly. So today, Dr. Rodis and I want to talk to you about consumers. And Christin, and you already know this, consumers are talking with their feet. Many have dropped out of and resigned from existing employment arrangements. Healthcare purchasers are really scrambling to offer superior benefits to attract and keep employees. And many purchasers are looking for alternative ways to offer better benefits, including direct contracting and alternative payment methods. How can we use this distrust that the average person has relative to performance of our U.S. healthcare system as a catalyst for change in an optimized system? So that's really the scoping thought. We're here today to talk about the vision for a better way. And before we get into this whole thing about the consumer in a better way, I'd like for you, Christin, to give the opportunity to talk about the thing that you talked the most about. Take a moment to describe for the audience your views related to employer purchaser fiduciary responsibility and exactly how employers can materially improve their plans for their beneficiaries by adopting accountable relationships that ensure value. I'm sure we could talk about this for an hour, but I'm going to ask you to keep it tight here because we're going to get right into our subject.
Sure. Yeah, I think, being a health plan fiduciary, and we could take an hour, but I'll try to be concise, it should be taken very seriously. And I think that it can really be broken down into three components, right? There's the responsibility that comes with it, and we'll talk about that. The liability that comes with being a fiduciary. And what I think we'll spend the most time on this talk really is about the opportunity that being a fiduciary can be. So what are the responsibilities? To put it broadly, being a health plan fiduciary under Arista means you run the plan for the sole and exclusive benefit of plan participants and beneficiaries for the sole exclusive purpose and paying reasonable expenses. So that's sort of the lens through which you should make your decisions. So being a prudent purchaser of healthcare, ensuring your contracts give you access to claims data, not engaging in prohibited, self-interested transactions. That's really the responsibility bucket. And then there's the liability bucket. So under Arista law, as a fiduciary, you can be held personally liable for a breach of that fiduciary duty that we just talked about, before. And it's a lot of responsibility and a lot of potential liability that really requires that you pay attention and protect yourself, whether that's in the form of professional liability insurance, seeking safe harbors, by doing really smart things, and just taking, again, that role really responsibly and letting that be the lens through which you make your decisions as a health plan administrator. And then finally, opportunity. Again, this is sort of a great segue into, I think, the meat of our conversation, because a firm understanding of your fiduciary responsibility and liability inevitably leads you to seek solutions and a path that, give you value as a purchaser. So as a purchaser, how can you move to value and drive change for your plans, that inevitably and unavoidably will drive change across the system? That was great. Enough? Okay.
No, that was good. I'm very impressed. Typically that takes an hour, right?
Yeah.
So that's terrific. So let's move into the topic du jour. And our country's in a really strange place. COVID and other events have really sown distrust of traditional institutions and leaders. Many public policy edicts seem to be predicated on questionable data and reasoning. And many employees have dropped out of the workforce, as I said at the beginning, and employers are really having a hard time attracting and keeping them. Many employees seem to distrust our health system. And it appears that there are new expectations from consumers around what they want and what they need. does any player, consumer, purchaser, provider in this new model understand their role? And are they prepared to act? That would be one question. What credible resources are available to these players to appropriately evaluate these new expectations from consumers and their wants and their needs? I know that's a huge question. And I mean, with 820,000 members to deal with, I'm sure you've considered this.
Yeah, so I'll sort of take them in turn. First, I think it's really important that we sort of unpack the language that we're using here and understanding sort of the role of consumer, purchaser, provider, right? I think the simple answer is generally no, because the roles are confused and conflated, right? In part because, like I said, the language we use is very confusing. Often we'll hear folks use the term payer referring to an insurance company or an ASO carrier. And I don't think that that's really the right description, right? Because the ultimate payer is, I think, whether it's the purchaser, it's who's paying for it. And, I think as we alluded to earlier, it's state governments, it's federal governments, it's the employees, and it's the employers. So first, I think that who is the consumer? The consumer is the consumer of the healthcare services. And in some ways, they're ultimately the payer, right? Through their premium or through cost sharing or even foregone wages. The purchaser, in my view, is either that self-funded employer, a government entity that's in charge of purchasing. It's really the entity that has the purchasing power that aggregates all those consumers, right? So the consumer might be consuming the services, but the purchaser has the power here, right? Because they're the ones that control the contracts with, whether it be through an intermediary or if they are engaging in direct contracts. The consumers are sort of at the behest of these purchasers because they are the ones that have negotiated with the BUCA or the PBM, right? And the consumers can be somewhat passive. So finally, there's sort of the providers, and this is a large bucket that, is hospital systems, physicians, et cetera. And, these are stakeholders that, in my opinion, these three, consumers, purchasers, providers, should have the largest voice at the table. Yet, one of the missing categories here is that intermediary, right? The TPA, the carrier. And I think if we look at the system as it exists today, they have one of the largest voices and really outsized power when they're nothing more than an intermediary when it comes to, like I said, the consumer, the purchaser, and the provider stakeholders. So what can consumers do, right? That's what we're talking about. I think that consumers have to demand to be treated, with dignity and really as the ultimate payers of the healthcare services that are being paid for. And they have to be more demanding of the industry that they've bankrolled, right? Purchasers, going back to that fiduciary role, they have to take that role more seriously because, as I said, it's they who hold the power and indeed the legal obligation to make those demands on behalf of their consumers. And so now for the providers, sort of that last bucket. And for me, this is the most difficult one. I don't know the exact percentage today because it seems to just be increasing sort of so quickly, but the number of physicians that are employed by hospital systems, right? Or the number of physicians that are employed by carriers. Neither of these institutions generally have an interest in lowering the overall cost of healthcare as a nation, right? So this is where I struggle the most, but also, I believe that the first two groups, i.e. consumers and purchasers, they can have the most impact in driving meaningful change, especially after the COVID pandemic when the consumer is really front and center.
Yeah, that was a really terrific answer, and it gives us a launch spot here. So I'm going to have my friend and colleague, Dr. John Rodis, do the juxtaposition. Certainly John and his background and experience, and speaking as not only a provider but as a health system representative, he has a really unique perspective. John?
Yeah, Christopher, it's great to see you, and
You as
thank you.
well.
That was a great answer. And if I could just pick up on your answer, since, as you say, the largest, we use your word purchasers, the largest purchasers of healthcare are the federal government through Medicare, state government through Medicaid, and of course, federal and state government as employers that you know better than anyone.
Right.
Since that's the case, what role does public policy play in health and wellness? Kind of like 50 years ago, way before you were born, we had an anti-cigarette smoking campaign in this country that was actually very, very effective. And then if I could just pick up on that, what role do the purchasers have to influence public policy?
Yeah, I mean, I think, on your first question, this should be a no-brainer, right? But I believe that this is one of those areas where bureaucratic, like from a government perspective, where bureaucratic silos really turn what should be sort of a rational decision on its head, right? So an example, when I first read this question, it immediately came to mind, right? A very concrete, immediate example is a correctional facility, right? This specific correctional facility was experiencing a budgetary crisis. They needed to save money, and one of the driving reasons for this crisis was the health spend of the inmates. Right, their drug spend was enormous, specialty care, et cetera, diabetes, autoimmune conditions, inflammation-related conditions, hypertension. The common denominator here is many of these conditions could largely be influenced by food. Right? The food that these people were eating. Except because of this budgetary concern, they were also cutting simultaneously, and had been over the years, the budget, right, on food. So almost no more fresh fruits and vegetables, leaning primarily on processed cheap foods, right? And so what you could have paid five-star chefs to come in and cook for these guys for 5 years, could have been paid for with 10 prescriptions of Humira per year, right? But it was the silo of this decision being made in a vacuum and this decision made being in a vacuum, and not really a holistic approach to these individuals. I use that example because it's sort of the ultimate control, if you will. So, what is the answer, right, to the world's health and wellness problems? I obviously don't have that answer. I wish I did. I would be one of the entrepreneurs that's been part of the $30 billion tech boom. But I do see promise in an area like if we can build a system that no longer incentivizes people being sick in a fee-for-service world and focuses on keeping people healthy and out of the hospital. If we can achieve a system that it financially incentivizes that outcome, I do think the government, will not only have a role to play, but want to play a role. And I think that employers will push them to do so. We don't live in a world like that today, certainly. But I think, more conversations like this, we're more apt to get there.
Thank you.
It was a great answer. Just a subpart to John's question, and do you feel that you're able to influence health policy priorities in New Jersey? Certainly, we're dealing with that in Connecticut. We're seeing it in other states as well, where there hasn't been a coordinated health policy or a strategic plan of health policy, focused on care transformation and things of this nature. Do you feel that you were able to influence that in your position?
Not as a general matter, no. I mean, I think that certainly within the population that I was responsible for overseeing and administering through the health plan. But more broadly speaking, and again, this goes back to the silo, bureaucracies that exist, not just in New Jersey, but across the country and at the federal level. By and large, I'm going to guess, I think Tennessee is maybe an example that does this, but where, your Medicaid and your HHS and your DHS and your Department of Health and your state health plan and local and purchasers are actually coming together to make broad decisions to drive health transformation. That doesn't exist by and large. And I know that we talked about like the cost growth benchmark work, that type of thing. It's a step in the direction to move everybody, but when it comes to the underlying policy and how to achieve that, I don't know that a cost growth benchmark gets you there. It's very siloed, and I think influencing 820,000 20,000 people was important, but it certainly, our sort of sway didn't go further than that.
Good. I kind of led you into the next question. So you're an attorney, so you're good at not being led. But this one might be a softball for you. So I hope it is. And this is I guess the subheading for this question is, what do health consumers actually want and need? Or is that a bad question? Do we know? Are there different types of health consumers? Presumably, there are. So new healthcare consumers seem to value access to care, home, virtual, on-site, near-site, over other things, including credentials and this whole kind of opaque notion of quality. Whatever quality is, they don't really know. Lots of money is being spent on patient engagement and patient experience. When you were managing the state of New Jersey health plan, what did you and your staff do to assess what your consumers actually wanted and needed the most? So that's one of the questions. And what radical moves, or even not radical moves, did you make to address these needs? And I added to the end, what lessons did you learn in the process?
Sure. So I'll tell you what we did that was sort of radical in assessing what the consumer needed in our case. And that was, we asked them, right? And that's sort of surprising because not many people do. I mean, I remember when I first raised the idea of engaging in sort of a surveyed approach to our members, someone in political leadership sort of said, well, if you ask the question, you're going to have to open the responses, right? Like when you give people the opportunity to speak, they will. And I, sort of said, well, that's the point, right? So the purpose there was really twofold. I'm a huge proponent of giving an agency and voice to the consumer, right? They want to feel heard, number one. And then we actually want to know what they say, right? This is obviously challenging with a group the size of, the public sector in New Jersey. We had firefighters, cops, university professors, truck drivers, legislators, right? So I think you have to leverage your trusted partners. In our case, that was the labor unions, right? This is where the consumer goes for trusted, non-biased information. That's who they really saw as their ally in this space. And so if you partner and leverage that relationship, I think that, we could reach even more people. And they were very willing, like they want the labor side and union side really wanted to be able to show their members that they were listening and then show them their value proposition as an organizing entity, and really highlight and tout the benefits that they had worked so hard to negotiate for their members on their behalf. I think, we see a focus on NPS scores and engagement for one of the primary reasons is because so many of the plethora of point solutions that have cropped up and now exist in the ecosystem are driven by those two metrics, right? So there's a real focus and a hyper focus on them. But the other thing I think is consumers assume that if a Blue Cross Blue Shield or an Aetna or United or a Cigna puts a doctor or a hospital in their Blue Plus network or in their, whatever the du jour name of the super great network that the carriers, they assume that you're putting high quality providers in that network to provide a service. I don't think there's any sort of guessing that a network would ever include a doctor that wasn't highly competent in that particular surgery. I think that's a false assumption, right? And I think that this is where purchasers come in because they're the ones that know that, the biggest, broadest, baddest network in the world isn't what's best for their members from a quality perspective. I want the surgeon that does 500 of those surgeries a year, not 5. They're the ones that can demand that. Right? And demand access to transparency and quality information. So I put that onus on the purchaser to drive more change and to demand that transparency and quality.
So just quick follow-up here. What are some of the things that you heard from your consumers? We need this now. This is really important to us. Things that aren't necessarily intuitive. And and that may include, access to certain types of things, data, tools, technique. What are those types of things? We're flushing out this, what has traditionally been in healthcare, a unicorn, the healthcare consumer. I call it the ultimate oxymoron. What are some of those things that these consumers asked for, that they really needed?
Yeah, I mean, there's a few, obviously. One of the, if you're to look in sort of like the wellness space, if you will, would be that they don't want, a one size fits all solution, right? The idea, and I think Al Lewis I'll credit him with this. People don't want wellness done to them. They want a wellness program that works for them, right? I think, again, going back to I think the trust issue is huge. They want an understanding and a relationship with their provider, that they don't feel like there's an intermediary standing in the way to deny care. Do I think that that's truth? No. Do I think that the system we've built makes it feel like that? Yes. I think they're craving healthcare literacy, right? Sitting down and explaining what an EOB means and what all these acronym means to, recently to a family member, they felt so empowered afterwards. And I think people crave that and want that, because nowhere else in sort of their consumer lives does that decision mean more than in healthcare, right? And not only to be able to help themselves, but to help their family and their children and their loved ones and their parents. And then finally, and I think this was true in December of 2019, and this is true today, behavioral health resources. And that's, just very specific and actionable, but specifically in the adolescent space, that is a consistent, just having more access to behavioral health. And I do think that we've made some strides, and, I think there was like $5.2 billion in 2021 invested in behavioral health specific digital health solutions. So I think we're getting there. And I think that we've this crisis that is upon us is being addressed more quickly because of COVID, but the crisis has also grown. So, I could go on, but I think those are the three that I would highlight.
Yeah, that was great. And it actually gives us a great transition. Dr. Rodis just recently wrote a series of blogs specifically about what I didn't learn in med school, and that we're really not educating providers about what the consumer actually wants and needs and things like that. And it's a great transition actually over to John's next question.
Yeah, I'm going to ask you a couple of questions if I can, Chris. I'll try to do them in order though. Let me just pick up on Jeff's question first. I totally agree with everything you just said, but I have serious concerns with the existing crop of providers that we're going to be able to get there. Let me be more specific. So when we talk about payment reform at the macro level, what are we talking about? We're talking about those dollars spent, reallocating them to nudge providers to get to do what they're supposed to be doing, right? To get patients under their blood pressure under control, their sugars under control. That's the idea, right? But we don't do a good job at that today. We do a terrible job, actually. As you know, half of diabetics have a hemoglobin A1C, only half have a hemoglobin A1C that's normal. Only half of hypertensives have normal blood pressure. I just read a study the other day that showed that even when you go back to your doctor with hypertension and you have hypertension at that visit, the doctor doesn't change the medications, a so-called therapeutic inertia. So, and then according to Bill Besterman, fewer than 10% of patients are on the right drugs who have heart failure. So everybody talks about bending the cost curve for the folks at the top of the pyramid that are consuming all the healthcare dollars. We do a terrible job at it now. So how are these providers, let's say now under new at-risk payment reform models, they're incented to do this, how are they going to pivot and do that? Or what infrastructure are they going to have to make into their practices in order to do that? And do consumers play a role in any of this at-risk models?
So I'll address the consumer side first, right? So on the consumer side, I think it's, we can all agree it's quite a confusing and overwhelming system to navigate. We all know that, and to bring COVID back into it, over the last couple of years, like wear a mask, don't wear a mask, wear a mask, don't wear a mask, but wear this one. Eat, over the last 20 years, eat fat, don't eat fat, but only eat this fat, right? We espouse as an industry, like financial well-being and stress are so important to manage as a social determinant of health. And yet in the same breath, 1 in 6 Americans is almost put into medical, is in medical debt collections because of the healthcare that they seek, right? It's kind of exhausting, and it's really a system that has consistently failed consumers. So I would say if the role for consumers to play here, if I were to give them one responsibility or task, it would be, similar to what I said before, it would be to expect more from a system that you have paid so dearly for, and to demand to be treated as a consumer like you do. You demand that dignity and respect that you do in every other, consumer transaction that you engage with, and even more so, right? Because the stakes are high. So on the provider side, the move to value obviously is going to require infrastructure investments. And indeed, I presume that much of the technology and resources are available even, but are probably being deployed in other ways, right? And when I say available, I don't mean necessarily built, but there are resources at hand to, for example, like how much do health systems spend on revenue cycle management services or technology to increase their billing accuracy and collection rate, right? I'm always seeing a new company pop up that is advertising how great their AI is and predicting who will pay and how they'll pay, and how do we get more from the system, right? And even like how much are they spending, 30% of overhead is going to that insurance billing tango. How much are we spending there? And that delivers really no value proposition to the system overall. So if you were to deploy those resources, right, to value transformation, I think you have a budget neutral transformation from a capital expenditure perspective, and you certainly have a net positive from an outcomes perspective. Is it easy? Does it happen tomorrow? No, but I think if you have the demand from the consumer and the purchaser, and you change the system to financially incent better health outcomes and not more fee for service, I think we can get there. We just have to, reallocate and, sort of calibrate where we're putting those resources.
The real question I have in my mind is who on the provider side is going to be able to do this? You hit a couple of really important points that I just want to emphasize. And now I ran a fairly large hospital, and hospitals don't really, but to be fair, don't do healthcare. They do sick care, right, as you pointed out. And there's really nothing in it for them to reduce the cost, right? Because it's still predominantly a fee for service business. The more they do, the more they get paid. And while everybody does a little bit of quality, nipping at the edges, incentives, the reality is that by far, on a nominal basis, the bulk of the dollars come in from, as you know, high margin procedures. As Jeff said, I'm writing some pieces on what I didn't learn in medical school. And the truth is, in medical school, 40 years ago and today, we still teach predominantly diagnosis and treatment. As Marty McCarry, I heard him say once, you say gout, I say colchicine. We're taught that's a diagnosis, how you make it, and here's the medication you use for it. We're not really taught anything about health, wellness, disease prevention, disease restoration of health when you have a chronic disease. So instead, we just watch patients evolve from, kind of normal people into obese people, or diabetic people, or hypertensive people, then have heart failure people, and then have kidney failure, and then they're at the top of that pyramid. So how are those providers, forget about payment reform. Payment reform is not going to solve that, right? How are those providers going to be able to pivot, especially since now many of them, as you pointed out, work for the hospitals and health systems that really don't have a vested interest in doing so. And Steve mentioned Governor Levitt's book. We just heard Governor Levitt on a podcast the other day. As you know, he started a university with Western governors called Western Governors University to really educate the future healthcare providers. But we're going to be short more than 100,000 primary care physicians, more than 1 million nurses in the next few years. I have serious concerns about who or what is going to provide the service. Do you have any insight into that?
I don't. I think, are the existing providers within the existing institutions, i.e. the hospitals and the way that they by and large do business. I know there are exceptions, or the, carrier employed or owned physicians. Are they going to be the catalyst for change? Short answer, no, right? And the current environment, it is hard to, I don't know that any physicians employed by these hospitals and health systems can execute that type of pivot in the absence of a systemic infrastructure change, that would, move this transformation along. That being said, right, there was a day before, the passage of Medicare and Medicaid in the 60s, that spawned really fee for service, that a doctor would sit at a bedside and treat a patient and not a time slot, right? It rapidly changed because the fee for service model was incentivizing quantity over quality, right? That's really what changed. I mean, I think if I read my history books enough, that's really the moment in time when we saw that change for physicians. And then, why special, if you, I think Dr. Bricker on one of his videos the other day was highlighting, the children of specialists always become specialists, right? Because they know that they're going to make a ton more money. The children of family physicians become specialists. Some will become family physicians, but most know that they're not going to make a lot of money, so they become specialists. And by and large, our family physicians are made up of first-generation doctors, right? That should say something, right? But I go back and I say, I think that transition shows us that behavior change is possible. I think the real question we have to ask ourselves as healthcare policy leaders, not just in the, this is on all of us, because it's a problem that we all have a role in fixing, not just the providers. Do we have the political will, right, to push for policy changes and push our political leaders that should be accountable for the mess that has sort of been made of the healthcare system? Do we have what it takes to take these hospitals to task, right? And in terms of demanding value for what we're paying for and overpaying for? And do we have the political will to take on the big, legacy institutions like the carriers and the BUCAs and the big 3 PBMs? I mean, that's going to take some, what I like to say, testicular fortitude, John. But I think with those things, if we have the will and if the purchasers are educating themselves, again, I say purchasers, those that are purchasing healthcare and paying the cost, as the doctor indicated earlier, we will lose our place in the global competitive, race if we continue to move towards and beyond 20% of GDP. This isn't money that's generating a service or a value to anybody else in the world. We're not exporting healthcare and better health outcomes. We're getting nothing for what we're paying for, and we will lose our place in the competitive market on a global scale if we don't do something. So I hope that we have the will.
It's actually, I'm going to kick it back to Jeff, but it's actually in some ways worse than that, in the sense we are now bringing disease to other countries through our Western diet that you alluded to earlier. I read something not too long ago that said in China that obesity was not a problem until about 30 or 40 years ago. And now, I don't know, maybe you've probably been there, but I have with Dr. Schutzer actually, and there's a KFC on every corner in Shanghai. And I'm not picking on that company, but I'm just saying that we've westernized their diet. So we took them from a plant-based culture to now a largely high saturated fat, high salt, high sugar diet. And there's going to be more diabetics in China in a few decades than there are people in America. So it's really kind of scary. And as you point out, it's exhausting. I guess, and it's not really a question for you, it's a comment. I have grave concerns, frankly, that without significant medical education reform, we're not going to get there. Concomitant to those years you talked about from the 60s and 70s, the other thing that happened in medical education spawned all the specialties. So all those specialists you were referring to really didn't exist 50 years ago. Those were mostly a relatively new event. And of course, then the payments also funneled, as you point out, into the highly specialized proceduralists predominantly. And that's how we got to where we are today. Now, how we're going to get back to where we need, or go forward, I guess. I don't know if it's going back. We really, I think, need to go back, right? I think patients want to be treated, you hit it on the head, who's taking care of me? I don't want to be the sum of my parts. I don't want to go to one doctor for my kidney, one doctor for my heart, one doctor for my knee, one for my hip, one for my head. Who's going to take care of me as a patient, as a person, and provide me the tools and skills and advice and education I need? I just don't know who's going to do that. But let me kick it back to Jeff. So that wasn't really a question; that was just a comment. But I'll let Jeff pick it up with questions.
So I'm going to give you another question. And prior to getting into health technology investment and all of this sort of thing, it kind of flows from that last question a little bit, and it goes back to the beginning of this conversation today about where we are at this moment. That suddenly there is a consumer that has different expectations from the system. I want to be seen at home. I want to be seen virtually. I want to have better access. I want to be treated as a human being and not have to wait the way that I have in the past. These new expectations and also the needs of purchasers. It seems to me that suddenly, Steve's question from the introduction, where are the purchasers? Why don't they take agency that healthcare is 18% of our GDP? Suddenly, this is a big deal in our country. That spend for healthcare, the second largest expenditure after earnings, is a big deal for attracting and keeping employees. So my question for you that flows from that is, there's things happening around the country. 16 years ago, Professor Porter and Elizabeth Teesberg wrote Reinventing Healthcare. And what did he say? He said, our healthcare industry is ripe for disruption because of the opacity of it and what have you. Do we have the right ingredients right now to create these marketplaces that purchasers are going to go to using at-risk and assigned advanced primary care, steering into warrantied APMs? I mean, we're seeing companies like One Medical and Village MD and Vera Whole Health and Eversight and other companies like this that are saying to purchasers, we'll take on total cost of care for you, we'll warranty it, and we're going to give you better outcomes. We're seeing companies like Centivo and Collective Health out there saying, we have platforms that we're able to do this on. How do you feel about this? Is this a movement at this point?
Oh, I think it's definitely a movement. And I think it's a movement with momentum. And I think there are a couple of things that might stand in the way or take the wind out of those sails, right? That we need to be very cognizant of and protect against, right? And that is sort of, we have to understand how much the entrenched systems and those that benefit from status quo, how much they will fight to kill innovation and disruption that will threaten their business model. It will not just happen, right? It's going to be a battle, right? And so whether that battle comes in the form of sort of blockading data, if you're an employer who your employees insist on having a shield and a on their card because that's what they've always had, and they basically hold you hostage, or whatever the case may be, I do think we just, again, purchasers have been handed like a silver bullet, really, in the form of the Consolidated Appropriations Act, which says you not only have a right to your data, you have a legal obligation to not enter into a contract that precludes you from getting it. Price and quality data, right? You now have a fiduciary obligation to know all of the fees you're paying to your broker, to your consultant, to your TPA, to your PBM, direct and indirect, tangible, or direct and indirect, financial and otherwise, right? They have the resources, and hopefully Jeff and people like us talk about this. But at the end of the day, I need the C-suite to say, I'm going to move. I'm going to do this, right? So yeah, I think there's a movement afoot. I feel like we are. I don't think it's going to be sort of this gradual long uphill. We'll be having these same conversations in 16 years. I think in 16 years, I'm hopeful that we're going to be looking back on this day and say that was the beginning of really sort of an inflection point, and things changed very quickly. I am hoping.
That's it. That's great. That's really helpful. So I'm gonna ask you one more question, and then we're gonna grab a few people from the audience with questions to ask as well, and we'll finish up with one summary question at the end of what as well. So literally billions of dollars have poured into healthcare in the last 24 months. Thousands of health tech entities and point solutions trying to disrupt the traditional system. Few, and this is my categorization, so you can challenge me on it. Few seem capable of integrating into at-risk provider systems or with other point solutions to create predictable outcomes or even to improve the patient experience. What are your thoughts around all of this investment and innovation? How do purchasers and consumers actually validate these solutions? Will some of these innovations succeed in truly making the system better and more predictable? And I'm sorry if I sound slightly cynical in that question. So, yeah.
Okay. So first, I think it's important. You said at the beginning or in your question that there are thousands of point solutions trying to disrupt the traditional system. So first, I would note that assumption should be questioned, right? Are they really trying to disrupt the system, or are they trying to take their piece of the $4 trillion pie, right? If their solution is trying to shrink the pie, the $4 trillion pie, then we can keep talking and we can go to the next step. But if they're just trying to take a piece of that pie and they're not bringing value, then, proceed to the question 4, right? So US-based digital health startups brought in over $30 billion in 2021. Huge amounts of money. These startups have investors to pay and returns to generate. And again, we're only getting to this part of the question if they're trying to shrink the pie and not just take a piece or grow it larger. Some of the things that concern me or I think you should look out for is, their ability, or I'm sorry, have they been bought or have they been courted, or will they be bought by some of the legacy players? There will be mergers, there will be purchases, there will be failures, right? And as of now, there are very few, if any, very few sort of good housekeeping seals of approval that I would trust as a purchaser. So independent evaluation is always the gold standard. This is quite difficult now, given sort of the data blockade that the carriers have, to do sort of any meaningful evaluation, including their value proposition. I would say in this space as a purchaser, like the Validation Institute is good. Some of the aggregated purchasing coalitions or, business groups but I say some, not all created equal. And I won't single out on the show, but I think that some are very trusted resources and some I would not necessarily look to the bottom of their flyer for a recommendation. But, another couple of rules of thumb, if they show you an actuarial paper that says this is how we've shown our ROI and it's been stamped with approval from any of the big consulting firms, they paid for that, right? And I would look at it and I would read it and then I would insist on my own validation. So I think that it's a noisy time, right? And I think there's a lot of noise. There's a lot of point solution fatigue, app fatigue. Do I think it's going to slow down? Because that's a big pie that a lot of people want a piece of. But again, I think if the employer or the purchaser can become the hub of the data, and then, Jeff, the things that you raised concerns about, in integrating with your direct primary care, advanced primary care, with your other diabetes management point solution to really drive engagement and value out of those product offerings. If you're in control of that process and how that data is flowing, you really will stand to benefit. If you're sort of reliant on the existing, carrier utility, if you will, to have those entities talk to each other, you might get some value. You're certainly not going to get the promise that they hold. And they do hold a lot of promise.
That's great. So we're going to take a few questions. I'm told that Kevin Bozick from Dell is on the call, and he is the chair of surgery at Dell Med School and the founder of the Value Institute, and a Porter and Kaplan disciple, and the partner of Elizabeth Teesberg. So we're among rarefied company. Kevin, if you can unmute yourself and ask your question, I'd appreciate it.
Okay, thank you. Thank you very much. And it's been real privilege to listen to this discussion, and a lot of it resonates with our ideals and the things that we're trying to promote. And so it's great to see that there are other like-minded people out there in other states doing similar things. One of the things that we have been working on is through a national payer purchaser coalition is what we call next generation alternative payment models, which are moving upstream from procedure-based bundle payments to condition-based bundle payments. And one of the things that we've stumbled across in this effort is the sort of tension that exists between primary care physicians and specialist physicians when it comes to managing risk. And so most of the risk models that are out there now are primary care based or health system based, where let's say primary care group is in an MA plan managing the risk, and then they are paying fee for service for all of the specialty care. They go out and try to identify low utilizers, don't really have much data on outcomes, but it's not a real effective partnership. And as we've tried to get into managing risk as specialists, we've come up against, hey, that's our business. We, primary care, we manage risk. We have the whole patient in mind. You're the specialist. We're going to pay you fee for service and expect that you, are low utilizers and are getting the outcomes we expect. And so the receptivity has not been what we expected. And I think just if you could comment on the need to engage specialists. I mean, most of the spending in healthcare is in specialty care. The need to engage specialists in these models and how we overcome that tension and overlap between specialty care and primary care when it comes to managing risk.
John, do you have something to say about that, or did you want me to take it?
No, well, you're the guest speaker, but I'll chime in. Kevin, first of all, it's good to hear your voice. I think I think primary care physicians have more leverage than they think with specialists. Now, I'm going to carve out orthopedics for a minute, because I know as an orthopedic specialist, like Dr. Schutzer yourself, you get a lot of patients from referral from other patients. You're not totally dependent on the primary care physicians. That's not really true for endocrinologists and neurologists and rheumatologists, cardiologists, as an example. They're very, very dependent on those referrals. Now, you and I both know the referral business is, I sent to them because we go to the same church, we play golf together, we went to med school together. We need to break that, and payment reform could go a long way. If you're held accountable as a primary care physician for diabetes, let's say, and you're working with an endocrinologist who is not easily accessible to the patients, not really working on a good nutritional plan with the patients, et cetera, you're going to start saying, you know what, I need a different endocrinologist, or you need to step up to the plate. So I think primary care physicians can leverage their power, if you will, vis-a-vis specialists, particularly for the chronic conditions we've alluded to before that are mostly medical chronic conditions, right? Hypertension, diabetes, for example. Weight's a little tricky, I think, in there, because who is that? I think primary care physicians need to be educated to take a history of what did you eat yesterday, what did you eat, the day before, and let's talk about some changes you can make that will actually make a difference. Because I do believe nutritional education and change behavior is probably going to be the most critical thing. That's where I was getting back earlier. I don't know, Christin, you want to add anything to that?
No, I mean, I definitely understand sort of the tension, and I don't think that there's necessarily an easy solution or solve. I mean, I remember as you were talking and framing your question, I sat on the Medicaid maternity bundled payment committee that we're looking to put together a bundled payment for the state of New Jersey's Medicaid population. And I just, we had a room full of, payers, purchasers, hospital systems, OBs, midwives, doulas, et cetera. And just this conversation about who was best positioned in the space. Was it the most trusted relationship with the doctor? Was it with the place of service that had the most financial stake at risk? And that would be like the hospital where the birth took place. So, I mean, it's an issue that I think will stay with us, but, to John's point, I think the more that we continue to elevate the importance and recognize the importance that the role that the primary care physician should be playing, I'm hopeful that, they'll be able to, we'll all be able to see that value and, they'll be able to work together and the turf war will become less of a war and more of a working relationship.
There's some other things happening in the marketplace from an incentive point of view. We have CMMI with their new direct contracting model, which is basically telling taking the provider group or the system and telling them you will take full total cost of care and you're going to figure out these care paths. That seems to be creating some really interesting discussions that we haven't seen before between and among systems and service lines and other organizations. We're also saying with the advent of all of these tech-enabled advanced primary care organizations around the country and the money that's come into them, that same type of incentive to create those longitudinal experiences, warranted episodes of care, even in the chronic space, to look at One Medical buying Iora, for example. Iora has figured out how to manage total cost of care. So we're starting to see that come into the commercial marketplaces as well. And even in our state here, the largest purchaser, 220,000 actives and retireds, went to an option that uses assigned primary care steering to episodes of care. They've had some difficulties in the middleware and the clinical integration that they're working to solve. There's been some balkanization of these episodes, but there seem to be some financial incentives moving to what you described. And thank you for that question. I'm gonna ask Peter Hayes, who runs the Maine Purchaser Coalition. If you would come off of mute.
Yep. Good afternoon, everyone. We've seen great presentation. I've got sort of a couple part question, but the topic of this was, the holy grail is really how do we get consumers engaged? And I think at the top, and it's really kind of an oxymoron because actually patients really are paying just a fraction of the total cost of healthcare. It really is, for the most part, someone else's dollars, whether it's Medicare or the plan sponsor or whatever. But you kind of touched on a couple of things, but there are three buckets that I don't know if you've got some thoughts about. One is, what still amazed me to this day and age is just consumer awareness. In our marketplace, most consumers still think all healthcare is the same. They're just totally unaware of the unwarranted variation in price and quality. And it's like politicians. They know some politicians may not be straight, but my healthcare and my hospital are just great. Second bucket is, if you have any, and I guess on that first bucket, you talked about consumers need to be demanding. I wonder if you have any thoughts of where do they get a voice to consolidate up? There's no coalitions. There really isn't a real movement afoot that they can really do. I think that's really missing. Second piece is, if you have any thoughts about why are there so very few consumer protection rights? Almost in every other industry, there are protection rights from transparency and quality and cost. And the third bucket is, why does the healthcare industry as a whole seem to be exempt from all of the other regulations that seem to apply to other industries? And a good example of that is medical error. Preventable medical error is still the third leading cause of death in the US, and it's costing tons of money. If you look at, for instance, I came from the supermarket industry and we had delis. We had inspections. If we didn't pass basic sanitation rules, we were shut down. We couldn't do business. But yet Leapfrog has hospitals with patient safety grades of C and below that you have a 90% higher chance of mortality, and those hospitals still are allowed to operate. So how do we address some of those fundamental things that really are directed directly at the consumer?
So I'll take, if you don't mind, Jeff, on the consumer awareness, and I tried to touch on this just a bit, but variation in price and quality. How do they not know this, right? Well, you drive down any like highway and you see billboards, promising to change your life and save your life, and it's the greatest place with private rooms to have your baby. This is what consumers are getting, right? This is the information that they're taking in. What employers are talking, and there are some groups like 32BJ is a great example that has a great maternity program that is saying, if you go to this hospital, and we're going to incent you to go to this hospital, you will have better, they have better health outcomes, better quality scores, and so they're educating their members. But by and large, we're either sort of leaving consumers to this information vacuum that's being filled by the hospital systems that stand to benefit from sort of preying on that. And then number two, we as an industry and purchasers for consumers, and I'm talking about the big consulting firms of the world as well, and probably brokers. When you do an RFP, or when you've run an RFP, for example, for a carrier, for your employees, what are the ways that you evaluate what are the ways we've evaluated bidders? How big is the network, right? Do you cover all the doctors that my members like to go to? That's called a disruption report. I mean, even in the language we use, we're saying change is bad, status quo good. Right? Do you cover all the hospitals my members like to go to? Because if you don't, I don't know that you can be in my network. We don't ask like, do you limit your hospitals to only those with an A+ rating? Because I don't want my members' back getting cut open unnecessarily for a spinal surgery, because I happen to know that, the leading cause of spinal fusion surgery is a failed spinal fusion surgery, right? That is, so we're just kind of leaving them to the wolves, and it's on us and that's why I think, and if I were to sort of, consumer purchaser provider talk about who has a lot of power right now and hasn't used it, it's the purchaser group. You're the one that's responsible for buying this. To your point, Peter, they're the ones that they're spending most of the money. They're footing the bill. Get your money's worth, right? And don't leave your members out into this vacuum. They're getting information. I mean, turn on your TV, right? And you're going to see Humira, Stelara, Skyrizi, any of these tens of thousands of, dollars medications, and now you're going to live a great life and do yoga all day, right? They're getting information. It's just not from an unbiased source with good information. So number one. And then on consumer protections, and I'm going to bucket these in the same sort of category, consumer protections and all of the, why is the healthcare system exempt from almost, any regulation that would apply in any other industry? Safety, transparency, antitrust, right? They're doing a little bit more, but not a lot. Why is nothing happening? Why is nothing happening? This goes back to my point about having the political will and testicular fortitude to stand up to the bullies in the room and demand that your legislators do something, and demand that Washington or your state stands up and says, I know you gave me $5 million last year, AHIP, but I'm still going to do what's right for my consumers. I know you gave me $10 million, hospital association, but I still need to, this law that I just passed, the surprise billing law, I'm actually going to uphold the rules that maintain the spirit of the law, right? That's a battle that's playing out right now. By and large, these are incredibly politically powerful groups that give a ton of money. I mean, pharma, how much money they give to continue completely unchecked in terms of pricing. So it's cynical, but it's true. Purchasers, you hold the power, demand better. If you have if you're Boeing, if you're a huge jumbo client, right? Yeah, the hospital system is a large employer in that local community or state and probably holds a lot of political sway, but so do employers when they aggregate and demand change. So I'll get off my soapbox now. You can tell I get really like fired up when it comes
Thanks.
to this topic.
Thanks for that question, Peter. So I'm gonna do one more question. Christin, this has been wide ranging and you're such a great resource to have. And the New Jersey plan, I think, represents like the 4th largest employer group outside of the federal government in the country. So obviously, this is a market maker, as are many of these plans that are out there. We tried to focus here on the consumer and on the purchaser right now, really having significant leverage. And, the question now is what's next? So we have many different stakeholders, as you could surmise, that were in this session, that signed up for the session. In our Moving to Value Alliance community has tried to create this focus on value and transformative healthcare to kind of keep the gas on as a community. As an influencer, that's you, do you have any advice or thoughts for our audience relative to a better way? Having been through almost 90 minutes here today, you just gave great advice to Peter, and I think he realizes it, and he's also an influencer. But general advice, coming out of this session, this is your denouement where you get to say whatever you want.
Yeah, I think that this advice, and it's not real wonky or in the weeds, it's more high level. But oftentimes we hear, the idea that change is not inevitable, right? And we use phrases like it's unsustainable. This can't keep happening, right? Like and we probably said that the healthcare costs were unsustainable when it was 12% of GDP, 15% and ticking up. It's sustainable as long as those in the seats that we occupy allow it to sustain, right? And so change is not inevitable in sort of the way we want it to move. And it takes energy and it takes work. And sometimes I get up in the morning and I feel like I want to bang my head against the wall because I'm talking to another CFO who says, I don't deal with healthcare, right? Like that's for HR. And we just, have to continue to put in the hard work, continue to have conversations like these with like-minded folks to continue energizing you to keep doing that hard work. And find the victories when you can and shout them from the rooftop so that consumers, purchasers, and policymakers can find wins to build the momentum that we need going forward.
That's great. And on behalf of our group and John, we're really grateful to have you today. We had tremendous enrollment in this session, and we will be circulating it wisely. Thank you for everything that you do. And thank you for everybody who joined us today. I encourage you, if you haven't already, to join our digital platform where we're going to carry over some of the questions that weren't answered at the end of this session and create a dialogue with the folks that are here as well. Thank you so much and have a great weekend.
Thank
you,
you.
Christin.